Hello, and I'm Dr. Amber, and today we are going to break down the high-yield vascular condition you need to know for NCLEX. So let's jump in. NCLEX will expect you to know the difference between arterial and venous insufficiency. So peripheral artery disease, or PAD, is caused by narrowed arteries, which limit the blood flow down to the legs. That decreased perfusion causes intermittent claudication, or pain with activity, as well as cool, shiny, and hairless skin. PAD ulcers are usually located on the toes and heels and are pale. In contrast, chronic venous insufficiency, or CVI, is caused by weak or damaged veins that impair the venous return to the heart. This causes blood to pool in the legs, which results in edema, aching in the legs, and skin changes from congestion, like brown discoloration, itching, and dry, flaky skin. CVI ulcers are located on the ankles and lower legs and pink. So let's keep this all in mind as we take a deeper dive. So let's start with PAD, which is once again caused by narrowed or blocked arteries, usually from atherosclerosis or plaque buildup inside the vessel walls that decrease perfusion. So what are our biggest risk factors? Well, first is smoking, because it is a powerful vasoconstrictor, as well as diabetes, because it damages blood vessel walls over time. If PAD is left untreated, it can lead to acute limb ischemia, and ultimately limb loss can occur. With PAD, reduced arterial blood flow means tissues are not getting enough oxygen. So we'll see signs such as intermittent claudication, which is pain with activity that is relieved by rest. So if you see this term on NCLEX, remember the leg isn't getting enough blood flow, and think PAD, not CVI. Other signs include skin that is cool and pale with weak or absent pulses. You may even need a Doppler to find them. Additional changes include hair loss and thin, shiny skin. And remember, PAD ulcers are worse where there is the least blood flow. So think the most distal part of the leg, such as the toes or the heels. Due to the decreased blood flow, the ulcers will often appear pale. So our goals with PAD are to improve blood flow and prevent collapse. So how do we do this? Well, first we must encourage smoking cessation and structured walking. The client should walk to the point of discomfort, rest, and then resume the activity. We should also give antiplatelets like aspirin or clopidogrel. And there are 3 critical things clients must avoid, including crossing their legs, wearing constrictive or tight clothing, and elevating the legs above heart level, because these all further decrease perfusion. So remember, on the NCLEX, if we have a client with PAD, they should dangle their legs, not elevate them. So decreased perfusion with PAD causes wounds to heal slowly. So we must prevent skin breakdown from sores, burns, and infection. So how do we do this? First, we should assess the feet daily. The client should also be instructed to apply moisturizer to the skin, but never between their toes, because this can increase the risk of fungal infections. The client should also trim their toenails straight across to prevent hangnails, and wear well-fitted shoes and break in new shoes slowly. Finally, they should avoid extreme heat or cold to the legs and feet to prevent burns. So when caring for a client with PAD, always assess the color, temperature, and pulses of the affected limb, because once again, they are at high risk for limb ischemia. So we should watch closely for signs of ischemia, which are the 6 Ps: pain, pallor, pulselessness, paresthesia, poikilothermia, and paralysis. If we see these, we should immediately notify the provider and anticipate an arterial bypass surgery. This surgery restores blood flow past the critical blockage points. But after surgery, postoperative care is key to protect the graft. We should instruct the client to avoid any type of knee flexion because it can compress the graft. And we should closely monitor for graft occlusion. Signs include absent pulses or sudden severe pain. So now it's time for our first NCLEX quick check on PAD. What is the location and appearance of ulcers with PAD? Pale ulcers with smooth edges on the toes or the heels. So what client teaching points are essential for PAD? They should never cross or elevate their legs because that further decreases perfusion. They should also be encouraged to exercise or walk and to immediately stop smoking. So what are these 6 Ps of acute limb ischemia? That's pain, paresthesia, poikilothermia, pulselessness, pallor, and paralysis. And remember, if we see the 6 Ps, we should immediately notify the provider. So now let's move on to CVI, which occurs when damaged or incompetent venous valves impair blood return back to the heart. This causes venous pooling in the extremities and leads to venous hypertension that is often worsened by risk factors such as obesity or prolonged sitting and standing. Risk factors include varicose veins and DVTs. And if untreated, CVIs can lead to venous ulcers and blood clots, both of which can impair mobility and healing. In CVI, blood pooling and high venous pressure cause leg swelling or edema, as well as aching and heaviness. They will also experience brown discoloration and dry, itchy skin caused by chronic congestion. And CVI ulcers are typically pink and on the ankles or lower legs. So for clients with CVI, the goal is to improve venous return and protect the skin. So how do we do this? We start by instructing them to elevate their legs, the opposite of PAD. They should also wear compression stockings every day, and encourage the client to use moisturizer daily to prevent skin breakdown. And remember to teach them the things they should avoid that further impair venous return. These include prolonged sitting or standing and crossing the legs. Once again, these activities worsen venous pooling. So now it's time for our NCLEX quick check on CVI. What is the location and appearance of ulcers with CVI? They're pink ulcers with irregular edges on the ankles or lower legs. What interventions improve venous return in CVI? Wearing compression stockings daily and keeping the legs elevated as much as possible. And finally, what activities should clients with CVI avoid? Prolonged sitting or standing. So now let's move on to an aortic aneurysm, or a dangerous dilation in the aorta that can occur either in the thoracic or abdominal cavity. Causes include atherosclerosis and hypertension. So we can see in this image, the left side shows a normal aorta, and on the right, we can see the aneurysm, or a bulging aorta. So a thoracic aneurysm, or TAA, is located in the chest cavity, and an abdominal aneurysm, or a AAA, is in the abdominal cavity. And with any type of aneurysm, the greatest danger is rupture, which can cause massive hemorrhage and shock. So aortic aneurysms are often silent until it is too late. But in the abdomen, watch for a pulsating mass, which is a classic red flag for a AAA. And if symptoms do appear, they often include a tearing back or abdominal pain, and dyspnea, hoarseness, and difficulty swallowing may occur if the aneurysm compresses on nearby structures. So here are the interventions you must know for NCLEX. First off, if you suspect an aneurysm, never palpate the mass because it can cause it to rupture. So although you may think it would be appropriate to palpate to assess for size, never do this. Once again, you can cause that aneurysm to rupture. We should also closely monitor the blood pressure and administer IV antihypertensives. This will reduce stress on the vessel wall. We should watch for signs of rupture, which include sudden tearing pain, hypotension, and tachycardia, basically signs of shock. And if rupture occurs, prepare for emergency surgical repair. And post-op care is key. We should monitor the pulses hourly and assess the client for hypotension or back pain. This will help us determine if there's any graft complications. And we should closely monitor urine output to ensure adequate kidney perfusion. So now it's time for our next NCLEX quick check. Which vital sign abnormality must be managed to prevent aneurysm rupture? That's hypertension. Remember, high blood pressure increases tension on the aneurysm wall and increases the risk of rupture. So what are the signs of aneurysm rupture? Well, we'll see signs of shock, such as hypotension and tachycardia, and the client will typically experience severe tearing, back, and abdominal pain. So now let's move on to Raynaud phenomenon, or peripheral artery vasospasms. This happens when the small arteries in the fingers and the toes temporarily vasospasm and narrow, causing blood flow to stop. It's often triggered by cold temperatures or stress, and with Raynaud, you'll see distinct color changes: white from the lack of blood flow, blue from the lack of oxygen, and then red as the blood flow returns. Clients may also report numbness, tingling, or pain during these episodes. So management of Raynaud is all about prevention. The client should be instructed to avoid cold temperatures and wear warm gloves whenever they are outside or even handling cold objects, such as an iced beverage. They should also avoid vasoconstrictors, such as caffeine or nicotine, because they make the spasms worse. And finally, for frequent or severe attacks, clients may be prescribed calcium channel blockers, which help improve blood flow. So now it's time for our last topic. Buerger disease is a rare condition that is similar to Raynaud's, but it is almost always linked to smoking. And it can be much more severe. It can even cause ischemic ulcers and gangrene. So what is the #1 priority intervention? Stop smoking immediately, because it is the key trigger for this disease. And in some cases, vasodilator medications are prescribed to help improve blood flow. So now it's time for our last NCLEX quick check. What should clients with Raynaud phenomenon avoid? Cold temperatures and vasoconstrictors, think caffeine and nicotine. So which drug class is used to treat Raynaud phenomenon? Calcium channel blockers. Once again, they relax the vessel walls and help restore perfusion. And finally, what is the top priority intervention for Buerger disease? Smoking cessation is key. So now you are ready to answer questions on vascular disorders when taking NCLEX.